Spectral analysis rules are going to be the same as we do anywhere else. We're going to use 60 degrees or less. We're going to record the velocities. If we suspect disease, we're going to use velocity ratio and look for post-stenotic turbulence. And if we do measure volume flow for some reason, we're going to make sure we open up our sample gate. In general, any peripheral artery, leg or arm, is going to have a multiphasic high resistance pattern. We're going to see this sharp upstroke in systole, a narrow peak coming back with a small reflected wave here. This reverse flow component is caused by the blood traveling down the vascular tree and hitting the high resistance arterioles at the end of the circuit and being reflected back. Then usually we'll see a third component, this little bit of antegrade flow in diastole. That little bit of antegrade flow is the result of the fact that in systole the vessels expand. They're nice and compliant and elastic, and that expansion actually holds a volume of blood out near the wall. And we can see that expansion when we watch the pulsatility occur in vessels. In diastole, when the pressure decreases, the walls contract back, again due to that elastic recoil. A volume of blood that's held out there gets propelled downstream, and that gives us that third antegrade component. Now, some vessels, normally, some patients have normal age-related changes where they've lost some compliance and lost some elasticity, so we may not see this third component, and we may just see two components to the waveform, but that's perfectly okay. So here we have a normal high resistance distal radial artery, but down here we have a little bit different pattern. Although we have a nice sharp upstroke and narrow peak, we see extensive diastolic flow through here. And this diastolic flow is indicating to us that this was a low resistance or a high resistance bed, and now it's become a low resistance bed due to all this blood flow through diastole. This can happen in a patient who's warm, as the hand is very temperature sensitive and causes vasodilatation. This can also happen if a person was exercising their arm or hand for any reason, and this is the type of pattern you would see. We don't want to see these types of patterns. Here there's a lot of diastolic flow, but look at the waveform itself. The waveform is prolonged and rounded. This is a tardus parvis-like waveform. It's delayed. This tells me right off the bat that this blood has moved through a stenosis somewhere. It's lost some energy. It's dampened out. You don't even need to know or appreciate what the velocities are here. If you just look at the waveform, you should be able to say that's abnormal. Same thing for down here. Don't even look at the absolute peak velocity. It's not important. The important part is here we have just one component, just this up and down here, this monophasic pattern in systole, no reverse flow, no reflected wave, no antegrade flow through end of diastole. So we know that this is an abnormal signal. And this type of pattern is observed proximal to a high-grade stenosis. All right, in terms of diagnostic criteria, there are no separate criteria for the upper extremity vessels. We're going to use the criteria that we also apply to the lower extremity. In general, these velocities are probably a little high for the upper extremity arteries, but what we're going to use really is the velocity ratio. When we see a ratio that's 2 to 1, we know we're dealing with about a 50% stenosis. When the ratio gets up to about 4 to 1, we know we're dealing with about a 75% stenosis. And you're not supposed to say all or none or always or never, but this is a time where this is almost always holds true. So 2 to 1 ratio, 50%, 4 to 1 ratio, greater than 75%. And again, we'll see this focal change. Now this slide, borrowed from SUNY Upstate in Syracuse, just shows again some nice anatomy here, where we start. Of course, the sternum is going to be kind of covering most of these vessels, so we're not really going to see the origin of the subclavian or the full extent of the brachiocephalic or innominate. But we're going to have to just come in where we can, and we see here, here's the innominate or brachiocephalic artery. We can see it coming up, and horizontally coming off this vessel will be the subclavian artery, as shown here. And coming up more, pointing up towards the head, towards the neck, it's going to be the common carotid artery. In terms of waveforms, the innominate vessel normally will have a fair amount of diastolic flow, as shown here. That diastolic flow is a result of the fact that the innominate gives rise to the common carotid, which gives rise to the internal carotid. So that is where that diastolic flow is going, up the ICA to the brain. Now the subclavian, again, feeding the hand, feeding the arm, is going to be more multiphasic high resistance pattern. When we see a subclavian, though, that looks like this, we can appreciate that there is something going on. Again, we don't even have to look at the numbers. You can see there's extensive spectral broadening. The waveform is kind of rounded. This is a stenotic signal, and in this case, we've got velocities here in this example peaking out of over 350 centimeters per second. Downstream, again, we would expect turbulence and rounding and blunting of the waveform as shown below. This is an upper extremity pulse volume recording and segmental pressure study, and we can see here tracings from the upper arm, from the forearm, and from the wrist. And on the right here, these are textbook normal. We see a small reflected wave, we see a nice sharp upstroke. On the left, we see this prolonged upstroke, this broadening here, and this widening of the pulse. We lose that reflected wave. We don't see much of a change from the upper arm to the forearm to the wrist. So what we can safely assume is that the problem is at the beginning, that there is probably something up here in the subclavian leading down so that when we take a look in the upper arm, we already see a change, and that change is probably the result of a subclavian artery stenosis. We can see that in these waveforms, and we can also see here in the Doppler pressure measurements in that we have greater than a 40 millimeter of mercury difference left to right. We don't really see much of a change as we go down to the wrist level in terms of a drop-off in those pressures. So this is a classic pattern that we would expect to see in a patient with a left subclavian artery stenosis. Continuing on out the arm, what we want to do is see these nice paired veins with a companion artery, and here's the axillary artery and vein. We see the Doppler placed in the axillary artery here with a peak velocity of around 100. We are seeing this multiphasic high resistance pattern, which is exactly normal. Further down the arm, we're going to follow the brachial artery. The brachial is very important because some general surgeons like to create dialysis fistulas using that brachial artery as an inflow source. They'll do the basilic vein transposition and transpose that basilic vein in anastomosis to the brachial artery, and that's why we really need to pay good attention to this, measuring the diameter and looking at the velocities, and again, a very textbook normal brachial artery waveform that we see here. Continuing on down, we'll look at both the radial and the ulnar. Remember, in the forearm, we've got one artery with two small veins on either side, the companion veins to the radial artery. This is the radial artery. These vessels up here that are all by themselves with nobody next to them, those are veins. And if you see these and they happen to be thrombosed, it's not a thrombosed radial artery. Look around. The radial artery has to have their veins next door, and that's going to be your landmark to distinguish this from this, and don't get confused. Again, the radial artery, multiphasic, high resistance pattern, except if your patient is hot or they're vasodilated. Some drugs can cause this as well, and we can see this vasodilatation. However, it is still normal. One of the other areas that we get asked to look at the upper extremities for are in patients undergoing a coronary artery bypass. We need to evaluate the radial and the ulnar arteries to make sure they're adequate, look for calcification, confirm that the vessel is still compliant, and we're going to record the diameter and the velocities within these vessels. In terms of measuring the diameter, it's probably best if we use a transverse view, and we can best appreciate that we're not oblique to this artery. You can do it sagittally, but we have to be very careful. In this example, the vessel measured sagittally was 2.6 millimeters versus 2.8 millimeters transverse. that's all right, but if somebody is borderline, we want to be careful and make sure we don't disadvantage them. This data was early data we compiled back in Albany, looking at males and females and diameters and velocities. Females did indeed have slightly smaller radial arteries than males, and as such, having the smaller tube to put that blood flow through, we had slightly higher velocities. Why we look at the radial artery and the ulnar artery is we want some sort of assessment of really what's going on to the perfusion to the hand, because we want to make sure that if we take that radial artery out, number one, it's a good conduit to use, but number two, that the digital perfusion will be maintained, because not everyone has a complete palmar arch. One way to test for that is with physiologic testing. Again, here's an example where it's probably better to use physiologic testing than arterial ultrasound imaging. Here we have PVR waveforms of the digits of the right hand, and then we've manually compressed the radial artery, and we repeat these, and we can see that these are textbook normal. We've got, again, a sharp upstroke, a narrow peak, the reflected wave here, no change all the way down, but when we compress that radial artery, we pretty much flatten these waveforms out. So we can safely say that this kind of patient, we don't want to harvest the radial artery to use for coronary bypass, because we probably will get some digital ischemia, and this is a result of the fact that the person is radial dominant and likely has either a small or ulnar artery that's not perfusing much, or certainly not perfusing adequately into the hand.